years old female resident of Shadra town, Lahore, admitted through emergency in the Trashikar Hospital of Lahore for 5 days, with the presenting complaints of fever for 5 days and joint pain for 4 days. Historian is her mother, and according to her, she is a known case of systemic lupus erythematosus with fair compliance and follow-up for last 3 years. And she was in her usual state of health 5 days back when she developed fever, which was sudden in onset, high grade, documented up to 1 or 2 degree Fahrenheit, continuous and relieved by taking oral medications with no diurnal variations. Fever was associated with joint pains, which was started bilaterally in knee joints, then bilateral, then progressed to involve bilateral ankle joint and then interphalangeal joints of the hands. Joint involvement was gradual in onset, symmetrical, non-migratory, and associated with swelling. However, there was no redness or deformity, and it was aggravated by movement and activity and relieved by taking rest and oral analgesics. Associated with these complaints of fever and joint pain, there was history of oral ulcers and rash over the face involving both cheeks, nasal bridge, and which was reddish in color. However, it was non-painful and non-itchy. Prior to the development of these complaints, patient has no history of sore throat followed by history of shortness of breath, palpitations, or any abnormal movements. Any history of glandular swelling associated with abdominal distension, bloody diarrhea, burning micturition, any history of nail pitting, skin disease, or any history of psoriasis in the family. And there is no history of any back pain, history of rash over the buttocks and feet associated with severe abdominal pain. And there is no history of any blood transfusion or prior drug intake. Uh, for these complaints, my patient was brought to a tertiary care hospital where she was already on follow-up, and she was investigated in the form of some blood test and urine test and X-ray and ultrasound of the joints. And the interpretation of these tests mother does not know, and patient is being managed in the form of IV fluids, IV injections, and the previous treatment was continued in the form of tablet methotrexate, syrup, calcium, vitamin D, and iron supplementation with the same dose as before. And my patient has been transfused once during this admission with pre-transfusion HP 5.6 milligram per deciliter, and blood was transfused after proper cross match and screening, and was donated by a close relative and transfused over 3 to 4 hours with no adverse reaction noted. And my patient has been improved in terms of fever, and there is partial improvement in joint pain and swelling. And my patient is going to be discharged by tomorrow with the advice of having follow-up on OPD basis. Actual history of my patient dates back to 9 years of age when she developed similar complaints of fever, joint swelling, photosensitivity, and joint swellings. Joint involvement was gradual in onset, symmetrical, non-migratory, and which associated and improved after treatment without leaving any deformity. And prior to the development of these complaints, patient also did not have any history of sore throat followed by shortness of breath, palpitations, any history of glandular swelling associated with abdominal distension, any history of bloody diarrhea, burning micturition, any history of nail pitting, skin disease, or family history of psoriasis, any history of blood transfusion, or any prior drug intake. For these complaints, she was brought to a local doctor, and where she was referred to Rashikar Hospital, where she was investigated in the form of some blood test, X-ray and ultrasound of the joints, and some urine test and some causes test. The interpretation of which mother does not exactly know, but parents were told that their daughter is suffering from a disease condition called systemic lupus erythematosus, and patient was discharged on tablet hydroxychloroquine and naproxen and some calcium and iron supplementation with the advice of having regular follow-up on OPD basis. Uh, Over the course of time, my patient has multiple 3 to 4 flares with worsening of the symptoms. When disease treatment was modified in the form of addition of tablet methotrexate, which my patient is taking on weekend basis, on weekly basis, every Saturday, Sunday, once tablet is being taken. And over the course of illness, my disease of my patient is complicated in the form of decreased height, weight, pallor, and multiple flares of the disease. However, there is no history of decreased urine output, hematuria associated with body swellings, and there is no history of severe chest pain associated with shortness of breath, and there is no history of frequent febrile illnesses or any history of bleeding from any side, TK bruises, or history of CNS symptoms in the form of fits, aggressive behavior, or mood changes. Uh, with the treatment taken, there is a history of abdominal discomfort, bony pain. However, there is no history of visual problems documented increased BSR, weight gain, or any history of jaundice or sudden failure in my patient. There are two admissions. There are two hospitalization, one at presentation and the second one during current admission. And my patient disease is being monitored with regular OPD follow-up, where in the form of anthropometric measurements, blood pressure monitoring, and some blood tests, urine tests, some blood tests and urine tests. However, renal biopsy has not been advised yet or performed, and activity of daily living of my patient has been compromised during the episodes of flare. However, she can dress, eat, and go to toilet and maintain personal hygiene in between. And she was born at term with no antenatal, natal, and postnatal complications. And she is vaccinated according to API with no additional vaccination has been advised or done yet. And she is developmentally normal and achieved all milestones at an appropriate age. And she was born to non-related parent and third in number of 5 siblings, and also other siblings are healthy. And she belongs to our lower socioeconomic status. Father is a laborer and earns about 25,000 per month and live in a rented house of 2 marla, 2 rooms, and share toilet. And disease has significant impact on the patient and parents in the form of missing schools, as she is not going to school for last 3 years, and on the parents in the form of work loss and financial burden and psychosocial stress. And the mother has inadequate knowledge about the disease, nature, cause, and complications, and duration of the treatment. However, she is concerned about complete recovery of her daughter.
Okay.
Uh, I have examined 12 years old girl who is conscious and cooperative throughout my examination, having no obvious signs of respiratory distress or dysmorphism. She has height of 126 centimeter and weight of 24 kg, which lies at less than fifth centile for her age and gender on gross centile charts. And she has pulse of 88 per minute and respiratory rate of 20 per minute, blood pressure of 100 by 60 millimeter of mercury, and she is afebrile. She is having erythematosus rash over the face involving both cheeks, nasal bridge, and sparing nasolabial fold, which is non-blanchable, not palpable, with well-defined irregular margins. And she has pallor, oral ulcers. However, there is no jaundice. There is no clubbing jaundice, lymphadenopathy, and BCG scar is present. On locomotor system examination of patient, she has intalgic gait and involvement of
Mhm.
symmetrical involvement of multiple joints involving bilateral knee joint, ankle joint, and interchangeal joints of the hands, with signs of active inflammation in the form of swelling, warmth, and limited range of motion. However, there is no redness, deformity, or contracture noted. Um, um, Abdomen of my patient is soft with no visceromegaly, with no evidence of fluid thrill, and apex beat is in the fifth intercostal space and mid clavicle line with normal first and second heart sound, and no pericardial rub is appreciated. And chest bases of the lungs are clear with bilateral equal air entry. And on examination of the back of my patient is normal. I cannot appreciate any renal biopsy mark, and CNS examination is also intact, and there are no signs of steroid toxicity, and Gower sign is also negative. I would like to complete my examination by doing fundoscopy and SMR of the patient.
Okay. Anything else you want to tell me?
Uh, no, ma'am.
Okay. Is there morning stiffness in your patient?
Ma'am, there was no morning stiffness in the patient.
Morning stiffness was not present. Okay. Is
Yes,
there
ma'am.
involvement of the temporomandibular joint in your patient?
Ma'am, no. I did not ask, but I have checked it. There is no involvement.
Okay. What about the cervical joints, cervical spine joints? Are they
There,
normal?
cervical. Yes, ma'am, they are normal, and there is no involvement of the cervical
How
spine.
did you ask in your history?
Ma'am, any pain in the neck, and
Okay.
I have checked on examination with flexion and
Okay. Any intra-articular injection was advised to your patient during this visit?
no, ma'am, no intra-articular injection has been advised in this visit
Okay.
or
Did you
previous
ask her?
visits.
Did you describe in your
Uh,
description?
no, ma'am, I forgot to describe, but I have
Okay.
asked.
Anytime before this intra-articular injection was advised to your patient?
No, ma'am, never.
Okay. Why
Intra-articular
did you
injection have
ask
never been.
for? Okay. Why did you ask for this glandular swelling in your patient?
Ma'am, as my patient presented with a history of fever and joint pains, and one of the differential diagnosis is systemic onset GIS, so I have asked about it.
Okay. All right. Is your patient taking folinic acid with methotrexate?
Ma'am, yes, she was taking, but I have to I forgot to mention that.
Okay. How many clinical flares in your patient are present over the last 3 years?
Ma'am, three players have been mentioned by the mother when tablet methotrexate was added, and it was improved after that.
Why did you ask for bleeding from any site?
Uh, Ma'am, although it is less likely with polyarticular polyarthritis to be a case of hemarthrosis, but I have asked to rule out any bleeding disorder.
So you are suspecting bleeding disorder in your patient who is
When
coming
it
to
is
you.
less likely, yeah, it is less likely as there are multiple joint involvement.
Why
Usually,
did you?
bleeding disorder
Okay.
present.
Why
Yes,
did you ask for jaundice?
ma'am, there is it is a complication of the disease in the form of hemolytic anemia when it can present with jaundice, and there is a patient is also taking methotrexate, which can also which is also hepatotoxin, can lead to jaundice.
Okay. So this is hemolytic anemia that is present in SLE patients.
Uh, yes, ma'am, it can. It is a complication of SLE patient.
It is hemolytic anemia. Are you sure?
Ma'am, it is yes, ma'am, hemolytic anemia, which in which
What happens to?
Crohn's direct. मैम इसमें
Yes, yes.
समटाइम्स ये होता है कि डायरेक्ट कोम्स टेस्ट पॉजिटिव होता है इन द एब्सेंस ऑफ हेमोलिटिक एनीमिया.
All right. So, is that why did you ask for jaundice?
मैम फॉर
Okay, you
methotrexate.
asked about for methotrexate. You asked for jaundice. Okay. Why did you ask for sudden pallor in your patient?
Ma'am, as my patient is taking again methotrexate, which is immuno bones, which can lead to bone suppression, so I have asked this particularly for that.
So, bone suppression is going to cause sudden pallor or gradual pallor.
Ma'am, it will cause a gradual pallor. Yes, ma'am.
Why you were so concerned about the renal biopsy? Even you have checked the back of your patient, there is no renal biopsy scar. Why you are so concerned?
Ma'am, according to new guidelines, every patient of SLE should be undergone renal biopsy. or there is a complication of SLE nephritis, which has severe consequences and can lead to end-stage renal disease. That's why I am
Okay.
concerned about it.
Okay. Is your patient having any genetic predisposition?
Ma'am, based on my history, there is no similar history among other siblings and family members. So I don't think so.
So you're not suspecting she's not having any genetic predisposition.
Ma'am, she she may have genetic predisposition uh, in the form of some HLA associations, and she is a female as well.
Okay, all right.
Hmm.
So in your examination, what about your malar rash? Is that raised or flat?
Ma'am, it was flat and non-palpable.
Okay. Was that discoid rash that was present at the malar area?
No, ma'am, it was not discoid. It was not coined in shape. It was a diffuse rash with well-defined and irregular margins.
So what's the difference between malar and the discoid rash if that is present at the malar area?
Ma'am, discoid rash is usually circular, well circumscribed, and coin shaped with scaly and crusty appearance, and it
Why
is
you want?
palpable.
Okay. Okay, that is palpable.
Yes, ma'am.
Okay. So any other rash you have checked in your patient?
Ma'am, I have checked for vasculotic rash at the lower extremities, but it was not present there.
Okay. Where you want to go for fundoscopy?
Ma'am, there is a complication of as my patient is taking steroids, and in SLE there may be a hypertension. So I want to confirm any hypertensive changes in the retina.
How did you assess psychosis in your patient?
Ma'am, she was well interactive and playful, having no depressed mood, or any abnormal behavior or
How was the
aggressive behavior.
okay, how was the oral cavity of your patient?
Ma'am, hygiene was satisfactory, and but there was a ulcer on the right side of the cheek.
Okay, what can you please describe that ulcer for me?
Ma'am, it was about 2 into 1 centimeter, with a reddish margin, and uh, well defined, with reddish margin and ill-defined border.
Was that aphthous ulcer?
No, ma'am.
Okay. Is your patient having any endocarditis at the moment you checked your patient?
Ma'am, there was no there was no history as suggestive, and examination findings suggestive of endocarditis.
Okay. How would you suspect endocarditis is present on your clinical examination? You told us very specifically there is
Ma'am,
no pericarditis. How would you assess for
yes, ma'am.
endocarditis?
Ma'am, tachycardia and any changing and murmur in my patient can will be
Okay.
present in case of endocarditis.
Okay. Is if just tachycardia is present, then what is this? We
No,
talk
ma'am.
about the inflammation. Okay. All right.
Uh,
What is your diagnosis?
Sorry, ma'am.
What is your diagnosis?
Uh, my diagnosis is systemic lupus erythematosus with relapse.
With relapse. Okay. Is that relapse or
Yes,
flare
ma'am.
up?
Ma'am, flare up.
It's flare up or relapse?
I'm sorry. I do not know about
Okay.
it.
What was the last duration the patient has taken the steroid or any medication? that's being given to your patient?
Sorry, ma'am.
What is the duration this methotrexate is being used in your patient?
Ma'am, it was started 1 year back and on weekly basis, and patient is taking one tablet on every Saturday, Sunday.
Okay, all right. Any other differential diagnosis of the presenting complaint?
Ma'am, I have thought about acute traumatic fever as my second differential and JIA on my as my third differential.
Okay, so is that rheumatic fever going to involve the small joints of the hands or any small joints?
Ma'am, usually rheumatic fever involves large joints of the body, and they are migratory in nature. But uh, uh, as there is presence of fever and polyarthritis, I have considered it to be a case of acute rheumatic fever on second number.
Okay, so that was on the second number. Okay. Any other differential?
Sorry, ma'am, voice
Any other
break on.
differential? Okay, any other differential?
Ma'am, juvenile idiopathic arthritis, JIA. Ma'am,
Okay,
JIA.
yes. Can this be a case of Lyme disease?
Uh, Ma'am, it could be a case of Lyme disease, but there is no history of any tick bite in my patient.
Okay, did you tell us about that?
No, ma'am, I have missed it.
Okay, how will you investigate?
Ma'am, after reviewing previous lab record, I will get some specific investigations and some general investigations, and specific investigations in the form of ANA, anti-double stranded DNA, and complement levels. And among general investigations, I will get CBC with differentials with latex count and ESR and C-reactive proteins, and I will get X-ray and ultrasound of the swollen joints. And to roll out complications, I will get chest X-ray, ECG, and echo during complete examination, RFTs, and I will plan for renal biopsy. And for complications of the for any for complications of the treatment, I will get the BSR levels, eye examination, and DEXA scans of the bones.
Okay, so you want to go for ANA levels. Why? Is that going to help you?
Uh, yes, ma'am. In diagnostic criteria of SLE, both ACR and SLIC, it is a part of my evaluation.
So you are going again and again for NA. Every time she's coming with the flare-ups, you will again go for ANA levels.
Ma'am, it is not necessary if I get on in previous labs.
Okay, so you will not go for ANA level if they are present, if they are positive in the previous labs. Is it so?
Yes, ma'am.
Okay, why
Yes,
you
ma'am.
want to go for anti double-stranded DNA antibodies?
Ma'am, because it correlates with disease activity, so I will get it again.
So you will not go for complement levels.
Yes, ma'am, I have mentioned it. I will go for complement levels.
Which complements?
Ma'am, C3 and C4 and CH50.
Okay, all right. What you will prefer? Is this ESR or CRP to look for disease activity?
Ma'am, usually on OPD basis, it is a good, ESR is a good test for disease activity.
And what about the CRP?
Ma'am, CRP can also help in disease activity.
Okay, so CRP is a marker of the disease activity.
Ma'am, ESR and anti-double-stranded DNA is the marker of disease activity.
Okay, so this patient is having, yeah, that is increased ESR, increased CRP. How, what is the value of the CRP in your SLE patient if that is highly raised?
Ma'am, there are two types of CRP in labs. low, less sensitive and highly sensitive. उसमें greater than 6 is I think significant है.
Okay, all right.
Hmm.
So, what is the role of the radiology in the assessment of the disease activity in your SLE patient? Is that going to help you?
Yes, ma'am. It can help in evaluating any joint erosions and presence of fluid in the joint for aspiration
Okay,
or
so
any
SLE is an
infection.
erosive arthritis.
Ma'am, it is a non-erosive arthritis. It will help in differentiating other etiologies.
Okay, so what are the radiology you are suspecting?
Sorry, ma'am.
Okay, all right. How will you manage your case?
Ma'am, first of all, I will consult the parents regarding the disease, nature, course, and treatment options available. And I will go by adopting multidisciplinary approach, including myself, a rheumatologist, nephrologist, physiotherapist, social worker, nutritionist, and staff nurse. And I will advise about some general measures such as taking high calorie nutrition and avoidance of fatty meals, along with calcium, vitamin D supplementation, and having regular follow up. And as my disease or my patient is falling under the category of moderate SLE, I will advise tablet methotrexate along with tablet hydroxychloroquine, and I will choose one of the steroid sparing agents such as methotrexate, azathioprine, MMF, or MMF. And I
She's
will also
already taking.
advise, yes, ma'am.
She's already taking this methotrexate.
Yes, ma'am. I will if I will switch the agent to MMF or azathioprine,
Okay.
and I will also advise avoidance of sun exposure and using of sunglasses and sunblocks when in sunshine.
Okay. Any other new drugs which are being used for the treatment of SLE?
Ma'am, for refractory cases, we have immune modulators.
Okay. Can you please tell me the name of that immune modulators being used?
Ma'am, rituximab and belimumab.
Okay. Which one is being used in your setup?
Ma'am, rituximab is being used in our setups.
Okay. Dr. Saab, I am the mother of this child and I am very much concerned about the wedding of my child. और डॉक्टर साहब शादी हो जाएगी इसकी?
जी, ऐसे है कि आपकी बच्ची की जो बीमारी है इसमें बच्ची बिल्कुल शादी कर सकती है बाकी बच्चों की तरह, लेकिन हमें इस बच्चे में कुछ एहतियाती तदाबीर अपनानी होती हैं, क्योंकि ये जो बीमारी है, एक तो शादी के बाद अगर प्रेगनेंसी होती है उसमें इस बीमारी के हमले होने का चांस ज़्यादा बढ़ जाता है। दूसरा, जो हम दवाइयाँ इस्तेमाल कर रहे होते हैं वो प्रेगनेंसी के दौरान जो है वो बच्चे के लिए नुकसानदेह साबित हो सकती है। दूसरा, ये बीमारी जो है बच्चे में भी मुंतकिल हो सकती है। इसके लिए हम एक तो ये करते हैं कि हमें जो जब भी शादी और प्रेगनेंसी प्लान करनी हो तो उससे पहले जो है आपने अपने गायनोकोलॉजिस्ट के साथ साथ रिमोटोलॉजिस्ट और पीडियाट्रिक कार्डियोलॉजिस्ट से कंसल्ट जरूर करना है।
Okay. What is the prognosis of my child?
मैम, prognosis, if overall prognosis is guarded, and however 5 year survival rate is above 90%, and 10 year survival rate is between 80 to 90%.
Okay. So you are very much sure about these percentage? Hmm.
Ma'am, according to the
Okay.
data,
All right.
yes, ma'am.
So this is all about your long case. Just 1 minute.
Yes, ma'am.